Good afternoon. We are privileged today to have Dr. Katie Bensinger, to discuss about Telehealth 10, a guide for a patient-assisted virtual physical examination. Kindly please mute all for all the participants, and we will have a designated time for questions. And kindly use the chat functions on Zoom for questions. And don't forget to complete your survey for CME. Next slide. We would like to thank HRSA, federally funded. This is a federally funded program. And also thank you very much to Texas Tech University Health Sciences Center, School of Medicine. Next slide. And TexLa is part of the National Consortium of Telehealth Resources. Click. Next slide. Next slide. And so at the end of the program or this educational opportunity, there will be a survey. Kindly complete your survey. Then I will give you now to the Dean of the School of Medicine, Dr. Stephen Lee Burke. Dr. Burke.
Thanks. Before I start, I want to thank Dr. Santos, Brent Majors for setting this program up for us. And a quick kudos to Dr. Santos. Several months ago, the AAMC produced guidelines on telemedicine competency. And I was very excited to send it to Dr. Santos because he kind of runs our program, until I realized that actually he was on the advisory board and actually wrote some of those competencies. So we've really appreciated him. Really pleased to have Dr. Bensinger with us today. She's an assistant professor of medicine at the University of Minnesota School of Medicine. She's a cardiologist with Essentia Health, and she's at St. Mary's Medical Center in Duluth. And she's actually written very extensively about the epidemiology of heart disease and about cardiovascular disease around the world from a public health point of view. She's also interested in rural health, much like we are. But last month in the American Journal of Medicine, she wrote a paper entitled Telehealth 10, a guide for patient-assisted physical examination. And many of you know that there's been a lot of very powerful editorials worrying about the loss of physical diagnosis in telemedicine, expressing very reasonable concerns that we all have. So Dr. Bensinger's paper was such a positive approach to maximizing the physical exam in telehealth using patient assistance. And I think you'll be really interested in what she had to say. And I know it'll give us all a lot of ideas as well on how we might also come up with ways of maximizing the physical exam as we depend more and more on telemedicine. So thank you for being with us, Dr. Bensinger from Duluth, Minnesota, where it's very cold, not as cold as Lubbock, Texas a week ago, but very cold. And we appreciate you being here, and we appreciate the contribution you've made to telemedicine.
Okay, sorry. Thank you so much for the opportunity to speak with you today. Can everyone see these slides now?
Yes.
And yes, it has warmed up here, and I'm glad you guys have gotten out of your cold spell. As a matter of background, I'm a cardiologist, and I do not, pretend to say that I'm an expert at all in telehealth and telemedicine, but I'm happy to share my experience. And I did work with one of my mentors, Neil Stone, who's a senior cardiologist at Northwestern. And early in the pandemic, we were talking about how a lot of our our lipid clinics and things have been, shut down because of the pandemic, and all of our patients, we were, forced to reschedule to see either via telephone or video. And so talking about how we were able to do that, and we decided that we should, write this paper together to kind of document and tell people in this situation that we were all forced to kind of be in, what was the best approach to doing this. So that's what how this sort of started. Again, this is not a comprehensive physical exam, really just focused mostly from a cardiovascular disease perspective, but I think, there's a lot of additional elements that you could add based on your specialty and what type of patients you're seeing. So the learning objectives, we're going to talk a little bit, define telehealth, because I think one thing I've learned in this realm is that there's a lot of different terminology. So I just want to make sure that the terms I'm using are clear for you. Describe this 10-step patient-assisted exam. Show a little bit of our data from Essentia Health on how visits changed, particularly in the Heart and Vascular Center, and then talk a little bit about future directions. So like I said, Neil Stone is one of my mentors. He's been on the last 4 lipid guidelines from ATP down to the 2013 and 2017 cholesterol guidelines. And he wrote this editorial about clinical confidence in the 3 C's: caring, communicating, and competence. And I think when it comes to whether you're doing visits in the clinic or doing visits via telehealth, you really it comes down to the patient doctor relationship or provider-patient relationship. And it doesn't matter how old you are or your gender or race, really depends on those qualities and skills that you bring to that room in that visit that create that special bond of trust, which is really fundamental to the patient-provider relationship. And patients have a lot more confidence in doctors who are have these 3 characteristics: who are caring, who communicate well, and who are competent. And it doesn't mean that you have to know everything, right? We know that one of the best ways to show that you're competent is by being honest and saying what you do and don't know, and taking time to ask a colleague or look something up if you aren't afraid, or you aren't sure, and not to be afraid to say I don't know. And in today's world, there's a lot of barriers to us being able to perform these very basic 3 C's. We have often strong pressures to see patients very quickly in the clinic and not spend as much time as we need. There's also just additional work and in-basket things that we're all doing in between seeing patients and documentation. But really, it comes down to the secret of caring for patients is caring for the patient, right? And really being present. And so one thing I've really enjoyed about doing these virtual visits in telehealth is that it does allow you often, with these virtual visits into people's homes and to see their family members, and you can actually develop a even greater patient-provider relationship by using telehealth. And sometimes I think we get in the sort of white walls of a hospital and clinic. So just in matter of defining telemedicine, the American Telemedicine Association defines it as the use of medical information exchanged from one site to another via electronic communications to improve patients' clinical health status. And this umbrella kind of encompasses a lot of different ways. And I think the Project Echo, you guys are doing a lot of probably teleeducation or teleconsultation. And there's also the kind of telepractice, which is what we're going to talk about, kind of the patient and having a provider, as well as research. And I'm the primary investigator on a number of pragmatic clinical trials, and we are using telehealth more and more for consenting patients as well as enrolling them in clinical trials. And I think this is a huge area that will continue to expand in the future. For the purposes of this talk, I am going to define a telehealth visit, what we call telehealth, as a visit where the provider is like in a central hub and the patient is in an outreach clinic. We call sort of the hub and spoke. So they're physically in one of our Essentia clinics, but just not at the same location as the provider. We call that telehealth. Our virtual visits are when the patient is often in their home, sometimes at work, and a provider is either in a central hub, or during the pandemic, a lot of providers were providing this service from home as well. And then our e-visits were patient at home, answering sort of pre-filled questions, and then a provider kind of going through it and responding electronically. And those we were using more for COVID type visits and other more scripted complaints. So the big things that I think where this comes into play is for both these telehealth visits as well as virtual visits. So a little bit about Essentia. We're a large healthcare system across northern Minnesota, northern Wisconsin, and North Dakota. There were 162,710 primary care virtual visits that were conducted between March and December of 2020. About half of them were telephone visits, 39% were video conference, and then 9% were unknown. It's just had to do with the documentation early on in the pandemic. We weren't capturing those visits accurately. The top 5 primary diagnoses in primary care were often for long-term use of opiates, hypertension, well child visits, diabetes, and anxiety. We contrast this a little bit to the cardiology visits. We conducted 12,479 virtual cardiology visits and 32,580 in person during that time period. A lot more of our cardiology visits ended up being telephone visits, often because our patients are older, often in their 7th and 8th decade of life, and just didn't have access to the technology that a lot of the younger primary care patients had. So only a quarter of our virtual visits were conducted using video conference. And again, 9% unknown, and those were earlier in the pandemic. Top 5 primary diagnoses under heart and vascular were coronary artery disease, chronic diastolic heart failure, paroxysmal atrial fibrillation, chronic systolic heart failure, and hypertension. Just to kind of show that you can do these visits for all sorts of causes, and we'll talk a little bit about our protocols and how we sort of triage folks. So this is a map of all of the clinics that either providers were at or that patients go to for telehealth across our system. So this is northern Wisconsin, northern Minnesota. This is Duluth, Minnesota. This is our Brainerd kind of hub hospital, and then Fargo, North Dakota. This is just a differences in the virtual visits between cardiology and primary care by age group. And so often, obviously primary care incorporates pediatrics, internal medicine, family medicine, and they skewed a lot more towards the younger patients. Cardiology seeing patients often in, like I said, the 60s, 70s, and 80s. And as terms of what percentage of the visits were video versus telephone at the time, a lot more of the primary care patients had video visits as opposed to cardiology. And this is our kind of trends in these visits. So, every week, this was our in-person visits for the beginning of the year. And then in Minnesota, we had a shelter-in-place order March 18th. And so, all the clinics more or less closed. And then we had previously been using telehealth for our outreach clinics. So about, once or twice a month, I would have a whole clinic day where instead of driving an hour and a half or 2 hours to one of our clinic sites, the patients would come there and I would be doing the visits from the office in Duluth. And we just basically ramped up that technology that we had across the entire health system for every provider. And so we were all familiar with this telehealth, but then what was new was the patients not being in the clinic, but being at home. And so the gray line is the virtual visits. And so very quickly by the beginning of April, we ramped up our virtual visits. And then as the shelter-in-place order got lifted early in May, you can tell that there was a return to normal clinic volumes with continued use of virtual visits. And in addition, we continue to do telehealth visits, which are not shown here, but virtual visits continue to be about 15% of all the cardiology visits still today. So virtual visits, in addition to the in-person, actually have allowed for us to exceed our pre-pandemic volumes in cardiology. And I think it's because of improving access to care, specialty care in our rural areas. So, just kind of this goes along with some of these trends that we're seeing, and the things that are going to influence the continued growth of telehealth is going to be continued innovation in the consumer technology and wearables. And I think this is a huge area that we had talked about early in the pandemic, but no one was really prepared to just send. I mean, they just should have sent to every patient a blood pressure cuff. Would have solved a lot of issues. And I know some health insurance companies, send patients Apple Watches, and and then if they use them a certain amount of time, they'll then they won't have to pay for them or something. But I think the wearable devices and remote monitoring is a huge area of need that we did not, that need was unmet, I would say, last year, and is slowly improving. However, a lot of patients are ending up just coming back into clinic. So I'm not sure if we'll have those market forces to kind of continue to develop that, but hopefully that's a huge area, obviously, of what we need for improvement. Another big gap was the electronic health records. So we had, built in some documentation and things for the telehealth visits, both on the outreach clinic side and the provider side. We use Epic for electronic medical records. So we have these things called dot phrases that would, capture the key billing information and things. But our smart templates and things for physical exam, for example, were based on in-person exams and really have not been well adapted to a patient-assisted or a virtual exam. There's also, as there's continues to be shortages in the workforce in rural areas, especially in subspecialty areas, I think that has definitely increased the demand for telehealth and will continue to influence and we've seen incredible growth in who are able to access, and patients really like being able to see a cardiologist from home if they have that technology and can do that. Obviously, the financial model really opened up the possibilities for this technology. Being able to do the telephone visits, which is, I feel, is far inferior to a video visit. It's really difficult to be able to do any sort of assessment when you can't even see the patient. But in the time where the clinics were all closed, it was sort of the best thing we had. And so the fact that those were reimbursed at the same rate early on was really important for being able to do this. And then just with increased demand, patients wanting to be able to see a provider schedule on their phone, when they want, just like they do for the dentist or the, go to their hair salon, they do it online. I think that'll continue to push us to do this more often. So with that as a little bit of a background, we'll dive into this Telehealth 10. So this is a 10-step guide to way to think about a physical exam that's being done virtually. And it works also for telephone visits. We've definitely done this with telephone visits. There's some video clues that we have added because it is easier, and a picture's worth a million words sometimes. And it, I think I prefer to do video visits if possible, and we've tried to move towards that as well. But it really, all of this is part of a triaging system. So, during the pandemic, we were triaging, who needed to go to the ER and urgent care, who could be seen on this, using these video or telephone visits versus who could just wait. And then we've learned now, we're a year into this, and people are still waiting, and we're seeing a lot of heart failure and strokes and delayed MIs and all these things because people are still fearful of coming in even now. So I think continue to try to reach people where they are is going to be really important, and using this as a way to help triage who actually needs to come in and who's good to just get refills and be seen next year is important. And again, this is not a comprehensive list, and to be full disclosure, I don't honestly do this on every patient, but there are definitely I have the benefit of most of my visits being 30 or 40 minutes, so I have a lot more time to be able to talk to folks and do go through a more comprehensive exam than primary care often. So step 1 in the Telehealth 10 is the vital signs. And this is one of the most challenging parts of in my opinion, the virtual visits. The telehealth visits, often the patient's coming in, your rooming staff is rooming them, they get all of the appropriate, all of our quality metrics, the rooming staff kind of go through, make sure the blood pressure gets checked, make sure the medication reconciliation is done, the allergies are updated, all of the stuff that our rooming staff is trained to do. And they have a weight, and if the heart rate is over 100, they'll get an EKG, and you end up having all of your nice vitals that you want to begin that visit. And when we do a virtual visit, often the patient's at home, we counsel them or in the instructions, if they have a blood pressure cuff, they're supposed to take it. We have instructions for them to sit quietly for 5 minutes, usually in the morning, not have any caffeine or be looking on their phone or listening to any disruptive news stories, and to check the blood pressure, check it twice, check it once in each arm, and take the lower of the 2 numbers and write that down. We also ask if they have a scale to check their weight in the morning. Often more and more people these days now have a thermometer and a pulse oximeter. Obviously with COVID, people wanting to know what those numbers are. And so if they have those, we ask for them to take them. So sometimes patients will be able to provide me with this information, but I'll tell you most of the time they don't. And it is kind of shocking how many patients are on blood pressure medications, either for their heart failure or high blood pressure, who don't have a blood pressure cuff at home. The skin assessment, I have a lot of patients who I treat for atrial fibrillation. We're always, concerned about bleeding and bruising. So we ask about any, new bruises, rashes, lacerations, any, I had a patient the other day I diagnosed with lupus in the clinic, had a nice amellar rash. I think that's another one where it would be great to have a video to be able to show them, have them show you kind of areas that they're concerned about. Often diabetic patients, you want to inspect their legs. Often a lot of people have, chronic venous stasis or lymphedema, or you want to inspect their feet for any sort of diabetic foot ulcers and things like that. And we can do that really easily in the clinic, or if they, telling you they're having problems, that's something that can be more challenging if you're doing this over the phone.
Dr. Bensinger, let me just up a little bit. Remember during your first step one, do you have your patient navigator take those vital signs so to maximize your time efficiently?
So we did not have the staffing to do that. A lot of our clinic staff were furloughed during the pandemic when all the clinics were closed. And so the providers were left on their own to basically do this. And then if the patients were having difficulty connecting, then I would have to call them on the phone and then try to walk them through the computer process. They did not have any sort of vitals, but the patients would get a phone call the day before as a reminder. And that's when they would tell them about, if you have a blood pressure cuff, you should do this. If you have a scale, you should weigh yourself. But they weren't, helping enter any data. They weren't doing any med reconciliation or anything like that at the time. And then when the clinics reopened, we were short-staffed. We had fewer MAs than we had before, and then all the patients came flooding back. And so now we're still doing these virtual visits without that support. So I think that's definitely an area that could use some improvement. I don't know what your situation is.
Well, pretty much the same, but I think it will just maximize, our time as a clinician if there's, a patient navigator and sometimes a telemedicine coordinator that could potentially help us. I think we could solve this problem together.
Yes. There's, I think there's a lot of things that we could improve upon. And like I said, just simple things like, all these patients should have a blood pressure cuff, and trying to figure out how to get them one and then get them to use it, would be tremendously helpful for preventing people from having to make that long travel, to the clinics and things. For the HEENT part of the exam, one basic thing that I run into a lot, I have a lot of 90-year-old patients, they can't hear me, and it's very difficult to do a phone visit with a patient who can't hear. And so sometimes you're sitting there like the Verizon commercial, like, can you hear me? Can you hear me now? And it's, ask about, if they have hearing aids or glasses, put them on, so they can see you. I've had to help navigate. I mean, a lot of, sometimes that you just can't do the visit. They just can't hear you. It just doesn't matter how loud you scream. It's just the tone of my voice just is not in their range, right? And so that's a big barrier, especially in older folks, to being able to do these visits and having them understand you. And we'll get to that, but I think closed loop communication. So when you're finishing a visit, especially a telephone visit, I have the patient say back to me what they understand of our plan, because I just can't assess how much they know without those video clues to help me. As a preventive cardiologist, I see a lot of patients with familial hypercholesterolemia or very high LDLs in the 200-300s. So one of the things we look for are xanthelasmas and corneal arcus, and you can actually look at these if you have a video, have the patients look up or down, and they can also feel their Achilles tendon, see if they're thickened. These are clues to familial hypercholesterolemia. The neck exam, comes into play for me more in our heart failure patients. We routinely are looking at the neck veins and looking for jugular venous distension. So one thing you can do is just ask the patient look over your left shoulder, look over your right shoulder, any pain or limitation. You can have them swallow, get a sip of water, see if there's any concern for goiter. I honestly haven't had it, been able to catch any of those. I may have missed a few, but that's just another thing to think about, especially for a new onset atrial fibrillation patient, for example. And then see if they've noticed any bounding pulsations in their neck. And one thing it is nice is often people are sitting. You can kind of have them turn their head to one side or the other, wherever the light is coming from. And you can try to look to see if you can see the veins while they're sitting up, then that generally means that their JVD is elevated. If you can't see it, then, obviously you're not gonna, it's hard to have them lay down. But, often I see people's earlobes, pulsating in the clinic, and that with their pitting edema, that that they're gonna need aggressive diuresis, maybe even coming into the hospital for that. So looking at the neck veins, if you can, with the video, is helpful. The lung exam, honestly, unless you have a digital stethoscope, which we do have for our telehealth, we have gone through a variety of different companies. There was a lot of static, and I honestly don't have one that I think I love. We're currently using the EKO stethoscopes. They're great for the heart, and I'll show you a tracing, but they're not as great for the lungs. So, when you're doing a video visit, asking patients just to take a deep breath in and exhale, trying to listen to see if they're coughing or wheezing. Obviously, if ask about smoking and things, we'll get to that in the social determinants of health. But, often you're trying to determine, I'm trying to determine, is there shortness of breath because of their heart or because of their lungs? And, I think having a stethoscope to the lungs is really kind of the gold standard. But in lieu of that, you can try to see if they're coughing or having other respiratory symptoms. Maybe they need to get a chest x-ray or pulmonary function test or something like that. I do think we probably end up ordering more tests because we don't have the thorough exam. I've definitely ordered more echoes and EKGs and things, and had people come in because you just can't tell than I think I would if I had the benefit of being in person with them and being able to do a more comprehensive exam. And we've also done that now that the clinics are back open, where you just say, hey, you're just gonna have to come see me next week, and I'll fit you in, or to come see my nurse practitioner, and we just need to get a good exam so we can figure out what to do next. Again, just looking for tachypnea, accessory muscle use. This was written during the time of COVID, and so looking for more respiratory issues that could be a sign of COVID infection. We're high on our differential. Often people see their cardiologists more than they would see some people more than they see primary care. So they don't want to cancel this appointment. They think it's so important they have to see their cardiologist every single year, and but they're actually having respiratory symptoms that were consistent more with COVID, and so we would have to send them elsewhere to get tested, and we didn't want them coming in. So this brings me to my favorite part of the exam usually, which is the heart. I think it's really great to just counsel people about, you say, put your fingers on your wrist, you try to feel the pulsation. Often people, can't feel it, and so you try to have a caretaker, or often people have a spouse with them, see if they can feel the pulse, and just count the beats. 1, 2, 3, 4, 5. And if it seems regular or irregular, like I said, we see a lot of atrial fibrillation, and I think this is something that's probably getting missed because people aren't coming into clinic. I think that's something that the routine vitals often would pick up. The machines will say, hey, this is irregular, and then somebody will get an EKG, and that's, with these video visits and things, it's just something that you have to have the patient aware of, or often, they have silent atrial fibrillation. They don't know that they are in this funny rhythm, and it really does require an EKG. So that's one reason we would bring people into the clinic then, to get an EKG. Often the blood pressure cuffs are a good clue, as well as if someone does have an Apple Watch, the EKG feature is pretty accurate at detecting atrial fibrillation and that irregularity. Obviously, again, a stethoscope would be great. And in a telehealth encounter, we've been using the echo stethoscopes, and that is great for listening for murmurs, as well as doing a basic EKG. The abdomen exam, basically I just have them ask them to push on their belly. Does it feel soft? Is there any pain? Do their pants fit tighter or looser than usual? that often can be more of a sign of edema. Some people hide their edema more in their belly than in their legs. And then also, asking about any scars. What are those from? Some people forget to tell you that they, had some major surgery. I've had patients who have had sternotomy scars, and they don't even know what it's from because they had it as a kid, and they go, I don't know, it was something when I was a kid, and you find out it was maybe it was just an ASD repair, but maybe it was something more serious. So always, when you're in person, you're always picking up on these sort of clues. It's a little bit harder when you don't have them in the room with you. The next is the extremities. This is a really important one, I think, that I pretty much ask people to do every time. I ask them if their hands or feet are colder than usual. You can tell if they have Raynaud's or any sort of sometimes vasculitis. We also have patients who have pulmonary hypertension who have scleroderma, so it can be helpful to actually see their hands and feet. I often have them push either their thumb or their first two fingers have them hold it down for a couple seconds into their shin and see if it leaves a fingerprint, and then I have them go up right below their knee and do the same thing and see if it leaves a thumbprint. If it does, then I have them go up to their thigh, and that's a good way to see how much swelling that they have, again, to assess kind of how aggressive you're going to need to be. If you're worried about DVT, or if they're having any calf pain or shortness of breath, one of the things that we would do in the clinic is see if one calf is bigger than the other, and you can instruct the patient to put their hands around their calves, and does one seem more swollen or larger or more red than the other, is a clue to a DVT, and maybe they need an ultrasound. Again, for those with high cholesterol, which again, when we see, we have them look at their Achilles tendon and see if it's lumpy or bigger than their thumb. Again, this is not very commonly seen, but you can get tendon xanthomas in people who have uncontrolled familial hypercholesterolemia. And again, we do for both telehealth visits and virtual visits, I have the camera, have them go and look at their legs and look at their sock line, and look for those rashes or venous stasis changes and things. I try to conduct the virtual visit as if I was with the patient, but it's there are barriers. Like I said, especially if patients have underlying dementia, have hearing issues. Sometimes people can kind of hide their memory problems, but if they have a family member at home, it can be really helpful actually to overcome some of these barriers by having the spouse present to be able to provide some input. They're usually not on camera, but they're usually at the table or on the couch nearby, and you can kind of hear them chime in when you're asking questions, and they often will remind their spouse to tell you things that maybe they had forgotten. So for kind of the physical exam, for neurological part of the exam, really this matters more for me in patients who you're concerned may have had a TIA or stroke, and you want to know if they still have any sort of residual issues. You can ask them or their family member to kind of hold the camera and have them do a variety of different maneuvers to see if they're having any gait problems. I mean, often just watching a patient walk from the waiting room to the clinic can tell you a lot about a patient's fall risk, how stable they are, what kind of weaknesses and things that they have. And so trying to, again, be able to get that information from a video visit is really helpful. I can also ask about a tremor, like I said, weakness, proximal muscle weakness if they can't stand up. I honestly, again, I don't do this on every patient, but I do think that's one part that I think is really important, especially in our really older folks. And this is the one that I think is the most important, the social determinants of health. I ask every patient every time about what their diet is, how physically active they are, what's the most active thing they've done in the last week. I ask about stress. Everyone seems, to be having a little bit higher stress than usual these days. And we have a questionnaire that we ask all the patients about food insecurities, transportation and housing issues, as well as if they feel safe at home. And then the standard questions about, have they used any tobacco in the past, week, and how much alcohol have they, approximately how many beers or how much alcohol they had in the last week, and then any IV drug use. And so these are, I just tell them, these are my standard questions I ask everybody. And I think often, again, you can tell by what's their surroundings, and if they have McDonald's bag next to their, on the table next to them, or if they, have a treadmill, you can kind of get a good sense of what their access is to being able to have a heart healthy lifestyle. So I think that's the 10 steps. And now I'll talk a little bit about, this is our physical exam in NoteWriter. And honestly, this ends up being more or less what I document for my telehealth visits. I've reviewed the vital signs, that they're alert, they appear normal, they don't have jaundice, they seem to have normal pulmonary effort. I usually ask where they are, who the president is, and then behavioral mood and normal. I don't think this is really well set up for being able to document a lot of what we just talked about, and I don't want to put things in that are inaccurate. So I try to just often, if I do want to comment on a positive finding that they had, then I'll put it in as a free text. This is an example of a patient I saw with the echo stethoscope. So this is my clinical assistant. She's listening to this patient with the digital stethoscope, and then I can hear the normal heart sounds, and then we have an EKG. So I think, the telehealth is here to stay. I think everyone now, has had exposure to it, at least in Duluth. We were, with all the clinics being closed, we were really forced to adopt this technology. It can be challenging. There's different populations, patients who are older, patients with cognitive impairment, patients with low technology literacy, that I think can be really challenging and can be left out of this new era of telehealth. And I worry, I was talking to one of my representatives when I was doing some advocacy work, and they were talking about how they want to get rid of the reimbursement for telephone visits, and they just wanted video. And I said, over half of our visits were telephone visits. I mean, you can't just systematically exclude everyone over the age of 70, and that's a huge barrier. And a lot of those telephone visits were really useful and really important, and I could get a lot of important information from that. And these are people who are very vulnerable, who are, at the time we weren't doing a lot of testing for COVID. We didn't have all the PPE. There's a lot of reasons why they should not be coming in, or they need transportation, they need people to bring them. And so I think just to say, oh, you can't do telephone visits, I think is really would be doing a big disservice to some of these populations who don't have access to that technology, or who have, just don't know how to use it. I think there's different acceptability, both by providers and patients, for doing these exams. There's some patients who adamantly refuse to do this, even though our nurses and scheduling folks had been, really trained in getting people to do this kind of visit. They were so adamant they needed to see the physician in person, and would often wait months and months to be seen, because they really wanted to be seen in person. So I think, but as people have done it, I think they realize that it's actually, a lot of patients we found it just as acceptable as an office visit. About half of the providers think it's as good as an office visit. I think in the current situation, it was better than nothing. But I think there's, obviously, we talked about rooms for improvement. I think the big challenge is in people who, when you need to bring in a third party. So for example, if I've had some medical students work with me and doing clerkships, it's very challenging to have them on a virtual visit day, because I'm just sitting here with my headset and they're on the computer, and we don't have the ability or haven't figured out the technology to add them as a third party and bring them into the visit. And I think that, trying to figure out how to best do that, maybe you're doing that, would be helpful. And that probably goes the same with interpreters. I honestly haven't had to use interpreters. We don't have a large non-English speaking population. So I don't know how that works, but I can imagine that would be challenging as well. And just meeting the patient's overall psychosocial needs. I think a lot of our patients come in so frequently that they know a lot of our clinic staff on a first name basis. And there's a lot of the social side of just coming to get their INR checked and just coming for their kind of routine visits for diabetes or whatever, that if they're at home, you may not be able to meet some of those social needs that they just need to be able to interact with other people. And then really trying to maintain that trust. A lot of these patients were patients I had seen before. Some were new to me, and I, would, try to introduce myself and try to gain that trust and develop that physician relationship, and in the same way that I would in an in-person visit. But it is challenging, especially if you don't have that video component. I think if it's just over the phone. And so, really being caring and understanding and sympathetic and I think are all really important. So kind of a little bit of, I think, in conclusion, there's some limitations, right, to telehealth versus in-person exams. For us, we don't have the rooming staff doing all of our medication reconciliation, doing vitals, doing all of our quality metrics, making sure that they're getting tobacco assessed and documented properly. I can tell you a lot of the physicians don't even know how to operate that part of the rooming tab in the medical record. And so we're very behind on meeting a lot of our quality metrics this year. And I think it just has simply to do with physicians not being trained in how to check all the boxes. We have something called an after visit summary that gets printed that summarizes sort of what meds you should be on. Here are the recommendations I have, here are the tests that I ordered. You don't have that, in these virtual visits. We do have an electronic version, which is great if you're seeing, a bunch of younger patients, OB or, patients who routinely have smartphones and things. But for my patients who are 70 to 90, they like that paper. They bring that paper in. That's their medication list. We did create some standard clinic documentation so that we can capture, the appropriate billing. Where's the patient? Where are you? Why was this a telehealth visit? What was the start time? What was the end time? All that kind of stuff that how we have in all of our notes now. And obviously there's some limitations to these other older and younger patients and also those in nursing homes. Nursing homes are incredibly difficult to do. I find to do telehealth visits, you basically just end up talking to the nurse. So again, listen to the patient, think about the 3 C's. Patients have confidence in doctors who are caring, competent, who communicate well, who explain things, talk directly to them. I always find that I keep looking at myself on the camera and I have to try to remember to look at the camera, so I'm looking at the patient, even though they're not there. And then I think incorporating more of the wearable devices and better, being able to improve our monitoring of patients at home will really help with the expansion of telehealth. But I think that this is a really technology that'll be here to stay and has really improved our access to specialty care in rural areas. And so I think whatever we can do to continue to make it better and teach people how to do it properly, it would be really important. So this is a little bit about recommendations for telehealth research and areas that we need obviously more work in. And I'm not going to go through all of those today, but feel free to reach out and contact me. I'm happy to take any questions that you have.
Thank you very much, Dr. Bensinger, for this very informative presentation. I myself was educated and reviewed on my physical examination, like my Rombergs and everything. And thank you very much. And I think there's a lot of wearables right now that will potentially assist us in our physical examination in the future. I'm actually trying the echo stethoscope, next week. And I'm actually impressed that you could able to record and sometimes detect arrhythmia and whatnot. And again, this is tailored to cardiology. However, as you mentioned, we could tailor this depending on our specialty. For example, for me, I'm a surgeon, so I look at the wound and incisions. Mm-hmm. And those were certain techniques to look into, make sure they press, make sure it's not tender, the color and everything. But I think the main thing though that showed in your presentation is that we debunk the myth that you cannot do PE virtually. Mm-hmm. So absolutely, we can do that. So I'm opening the, sorry, the table for questions. Dr. Bird.
I have a question. You mentioned that that your pediatricians do well child visits. Our pediatricians have been reluctant to do that, and especially head circumference. How do you approach that?
That is a great question. I know that a lot of the well child visits were converted, like I said, during the kind of March, April, May period. But then they found that a lot of kids weren't coming in for the routine vaccinations, even though after the visit they would say, you know, you're due for these and come in. And so they were one of the first departments to very quickly reopen because they were worried that kids were falling behind with vaccines. And so, I'm sure that same thing like head circumference and other measurements that are really critical to being able to make those assessments. But I think there, you know, at the same time, we were able to really implement a lot of our questionnaires. So when a patient goes to register for that visit and sign in, there's a series of questionnaires they fill out, and one of them is about the social determinants of health and food insecurity and housing, and that's all now captured in our electronic medical record. It does take them about 10 to 12 minutes to fill all that out, so they are supposed to log in, you know, 15 minutes early to get all that paperwork done. But there are some benefits, I think, to being able to have those kind of data captured systematically. But I agree, pediatric visits when you need height and weight and head circumference are just, you're just not going to get it, you know. But it's made, you know, like not well child, like ill child, flu, you know, visits much easier, right? They've, you know, I think that rather than bringing a bunch of sick kids into the waiting room and exposing everybody else in the waiting room, they've been able to do much more in terms of the sick care virtually.
Thank you.
It's not a question, but a good exercise, I think, for students would be to really put together a comprehensive list of what you can do in physical exam. You can check gait, you can check a Romberg, you can sort of check neck veins sitting up, you can even measure calves. There's an awful lot of things that we can look at, all skin rashes or ptosis. There could be a pretty comprehensive list, not that we would check everything for any one visit, but maybe just as a teaching method to make sure students understand in the spirit of what we've talked about today, there's a lot of things that can be done on physical exam if the patient is able to assist you.
Yeah, I mean, I remember when I was doing my second year medical rotations and we had those standardized patients, and you'd have to go through a totally complete exam on a perfectly healthy person, and it was just training you to you know, go through all those maneuvers. I think that there's a lot you can do. I think you're right that you could have standardized patients done virtually, and to, you know, you can still develop that, you know, provider and patient relationship virtually as well. And the way that you walk them through things, you won't have the stethoscope. You won't be able to hear bruits, you know, but there's a lot, like you said, you can still do.
So I may have missed it because I came in a little late, but so to me, the one of the benefits of having a specialist that can't be there is that in these smaller communities that we deal with is to have a provider there, either a nurse practitioner or you know, maybe could be a family doc or a general OBGYN that is now consulting with for, you know, a patient that may have a higher risk condition that can't get in to see the specialist, and to help consult with management. Is that something that you're doing also?
Yeah, that's a great point. So we have regional heart centers in about a dozen smaller communities throughout the Wisconsin, Minnesota, North Dakota area, and we have sort of a domiciled heart team. So we have a nurse, a clinical assistant, and usually a nurse practitioner or PA who are there full time. And then the physicians usually go to that outreach site anywhere from 1 to 3 times, you know, a week to see clinic patients. And so telehealth is not, our goal is not to replace that physical presence. It's just to be able to provide additional access and additional visits because some days you we also need someone covering the stress lab. So you physically need somebody here, but I can do visits in the morning because I don't have to be running the stress, the treadmill exams and things, but I need to be in the building in case there's an emergency or something, but I could do telehealth visits, for example, or virtual visits in the morning. So we are using it more as a ability to expand our clinic volume instead of having to send providers routinely. But I agree. I think that there's a huge benefit to having people available for the community clinics, and you're still going to need some in person. For example, all of our heart failure follow-ups still need to be seen in person. They're very high risk of having, being readmitted, and so those all get seen within 7 days by our nurse practitioners in our outreach sites. And then sometimes we'll do a later visit. Part of the cardiology consult, to be honest, is me reviewing all of the imaging. So I usually do that with the patient. I do listen to the lungs and heart, and I have caught aortic stenosis that on exam that is much more severe than what the echo is telling me. But for the most part, I have the benefit of the EKG being done, the echo being done, whatever, the chest X-ray, all the imaging, and so part of my consultation is going through that with the patient and providing my overall assessment.
Dr. Bensinger, excellent again presentation, and I think we're still looking for that elusive platform wherein we could do everything. Like in Zoom, by the way, there's a closed captioning, so people who had some hearing impairment could actually read. However, for those who are visually impaired, that's another problem, another issues. And I think there are some issues with regards to equity on how we could, help those with disabilities. And we're still looking for really the elusive platform wherein there are some platform wherein students could look and shadow us. Of course, we have to make sure we get the consent and everything. And I'm hoping we had this platform wherein this is hooked up with the laboratory, with your EKG labs, with your wearables, as well as with your pharmacy, and even your physical or rehab program. So you could do your exercise and everything at the same visit. That will be great, right? However, I think we're still developing this technology to make it integrated together. My question though, Dr. Bensinger, is is there any trick of what you do, to increase physician adoption of telemedicine in your institution?
Mandated. I mean, I think it is an expectation. It was an expectation before for our reach sites, and it was so that we didn't have to drive. So it was, we have providers who have to fly on a small 6-person plane up to International Falls, which is also to the icebox of the, America. It's up on the border with Canada, and there's risks associated with having to take a flight, 3 hours there and back, and being able to do telehealth. I do telehealth now for patients who are in International Falls, and so it allowed them to be able to not have to wait so long to see, clinic providers and things. So it's been just an expectation for us. And like I said, this started pre-pandemic. We were doing this for heart failure. We didn't have enough heart failure docs to go to all the outreach sites, and so they were doing telehealth. So the patients would come into these outreach sites kind of in that hub and spoke model. We were doing it for device clinic. So our device interrogations, they had a trained person in the outreach clinics that would do the interrogation, and then they would see the provider over the computer who would interpret the interrogation, make any setting changes that needed to be made. So it's just become part of our practice. And with COVID, and there weren't any clinic patients, it just became 100% of our clinics got converted. And then now, like I said, it's about 15% of our total visits. And so what I usually have is an 8 and 8:30 a.m. virtual visit on a clinic day, and then my 3:30 and 4 are virtual visits, which the afternoon ones are always challenging because I'm usually behind. So I would rather have more virtual visits in the morning because I can usually stay on I can stay better, a better time management actually with virtual visits because I can do my documentation while they're talking to me, and things in clinic I tend to get behind. But that's just me.
Any more questions or comments from the table or this group? Next slide. Just a reminder, you could put your cell phone and take a picture of the QR code, sorry, for the evaluation. So you could get your CME units. Next slide. Next slide. One more. And thank you very much, Dr. Benzinger. So this is our virtual challenge coin that we're presenting to you as a token of our appreciation. Waited for the mail for the actual challenge coin that our School of Medicine, is bestowing on you. Thank you very much. And I would like to ask Dr. Burke for closing remarks.
Well, again, I also like to express our appreciation. This is really very timely time for all of us, very timely to really consider what our future with telemedicine will be. Telemedicine is part of the Health Science Center's vision to transform healthcare. And again, I think Dr. Benzinger has given us a lot of ideas on how we can continue to optimize what we do. I do think she was, a step or two ahead of everybody else in the article that she published in the American Journal of Medicine, and should inspire a lot of people to continue to look at this type of approach to improving telemedicine. So thank you for virtually being here.
Yeah, thanks again for the invitation. It's been great to have this conversation, and thank you for all the work you're doing to really help advance this, because I do think this is a technology that's here to stay. It's one of the benefits, I think, of COVID-19 is that we've all now, it's come to the mainstream, and now we'll just got to make it better.
Okay. Thank you all for being here. And thank you, Dr. Santos.
Dr. Santos,
Yes.
could I see that little square, that code, the barcode, so I can take a picture of it?
I took back. Laura will put it back again, Dr. Jordan. Then while she's doing that, kindly remind everyone that on March 4, there will be a Project Echo webinar presentation again, this time by Dr. Disanaka. Go back. No, the barcode.
Oh, sorry.
The QR. There you go. That's the QD code. So QR code. So put your phone in there and you will go directly to the evaluation. All right. Thank you very much again, Dr. Benzinger. We really appreciate your presence in our webinar.
Great, and good luck with all the advancing, the telehealth with the AMC. I think it does need to be incorporated in the curriculum, and if you have any ideas on how to best teach students, I'm all ears. Send them my way.
Well, one of our enthusiastic students already working on probably quoting your article in this project that we're doing.
Great. I look forward to seeing it. Take care, everyone. Thank you.
Thank you. Have a good one. Thanks, everyone.